So good day, and welcome to the Bugs That Won't Go Away, Your Role in Delusional Infestation. This webinar is brought to you by the StopPests in Housing program. The Northeastern IPM Center receives support from the U.S. Department of Housing and Urban Development's Office of Healthy Homes and Lead Hazard Control through the U.S. Department of Agriculture, NEFA, to facilitate this program. StopPest's goal is to improve pest control and affordable housing by teaching everyone who works, lives, and plays in housing how to use integrated pest management. My name is Taisey, and I run the StopPests in Housing program. Since 2007, our program has worked with public housing agencies across the country to improve pest control through integrated pest management, or IPM. Through this job, I interact with extension entomologists, pest management professionals, and housing professionals. One of the many challenges that all of us face is how to deal with residents who are suffering from a pest that leaves no evidence and won't go away. The steps of IPM are to inspect the area, identify the evidence that is found, scale the response to the type and level of infestation, take action using a variety of integrated control methods, and then evaluate the effectiveness. With delusional infestation, inspection doesn't find evidence of a pest. Through this webinar, I hope you will understand how to identify someone who is suffering from delusional infestation and take appropriate response. I strongly believe that no one should have to live with pests, even imaginary ones. Today I have Dr. Peter Lepping and Dr. Nancy Hinkle joining us to share their extensive knowledge on this issue. Dr. Lepping is a psychiatrist with years of clinical experience. He is a visiting professor at Glyndwr University in Wrexham, Wales. I'm truly honored that he responded to my email after I read his review paper in Clinical Microbiological Reviews, and he agreed to share his expertise with this audience of mostly housing and pest professionals. Dr. Nancy Hinkle is a veterinary entomologist at the University of Georgia who works on insect and mite pests of animals, including livestock, poultry, wildlife, horses, cats, and dogs. She received her BS and MS degrees from Auburn University in Alabama and her PhD from the University of Florida working on fleas. She taught at the University of California for almost a decade before joining the University of Georgia in 2001. One of her current research projects involves a beetle that serves as a reservoir for salmonella. For over 20 years, she has worked on bird and mites that are found on songbirds and domestic chicken flocks. She has dealt with cases of Delusory parasitosis for over 25 years and currently handles 3 or 4 per week. Before we begin, a few administrative items. Everyone except for the presenter will be muted. If you have a question, please use the chat box and send the message to everyone. Chris Gonzalez and I, Allison, will try and answer your technical questions. I will keep track of your questions for our speakers and then ask them in the order in which they were received at appropriate times throughout the webinar. After the webinar, we will post the recording and the answers to any questions we do not get to in the hour. Thank you again for taking the time to come together today. And Dr. Lepping, I'm going to hand the presentation rights over to you.
Thank you very much, Alison. I presume that you can all hear me now. Welcome from a very snowy Great Britain. This is the first web seminar I'm doing, so it's a little bit strange to sit at my home computer with a cup of coffee doing this, when there's usually a big audience in front of me, but I hope that we can make this entertaining and informative. I work as a consultant psychiatrist in Wrexham, which is a town with about 80,000 inhabitants in North Wales, and I work as a professor for the Glyndwr University in Wrexham. I would like to acknowledge my main research partners, Roland Freudenmann from Germany, Tony Bewley from London, and Markus Huber from Italy, with whom I've published most of my publications. This is a talk that I've given before, but I try to update it all the time, and what you get today is basically the most up-to-date knowledge on delusional infestation. I'd like to start with a definition, and Alison told me that many of you are not psychiatrists, so I will go a little bit into what a delusion actually is to a psychiatrist. But essentially, delusional infestation is characterized by the fixed belief that one or one's environment is infested with insects, parasites, non-living objects, or small living creatures in the absence of medical or environmental evidence for this. For example, a typical patient would be an elderly woman living alone, possibly with a visual impairment, thinking that there are parasites or insects crawling underneath her skin. Another good example would be a 30-year-old man who might think that after an exposure to some very dirty environment has been infested with some kind of object. Occasionally people feel that these objects or pathogens might be part of their skin. They may say that they can see them coming out of their skin. They may also feel that they go into their lungs or other internal organs. And because they mostly feel that they're in or under the skin, they often then treat the skin with pesticides. This is particularly dangerous because they often use very toxic or very aggressive pesticides, and that means that their skin then does get secondary lesions, and that is the reason why they most commonly present to general physicians or actually dermatologists. I have also seen patients who believe that their immediate environment was infested, and that is where a lot of you pest control people come in. One of my patients was a woman in her 20s who was convinced that her house was infested with rats. She was so convincing that she even managed to get an article in the local newspaper lamenting that the local environmental office was absolutely useless in getting rid of the rats for her. In the end, after quite a long time of persuading, we managed to persuade her to take antipsychotic medication and the rats all disappeared. This is what usually happens, but you can see that the amount of suffering that these patients have is actually very high. Because if you imagine that either your body or your house is infested with whatever pathogen or pest, it's really a very big problem for your quality of life, because you don't want to be in that house. You really don't want to be in that skin that you think is infested. So we have a high degree of suffering. We often have social isolation because people clean their house or themselves all the time, or they may in fact think that they might be contagious, so they avoid social contact because they think they might pass it on to other people. Delusional infestation can come in different forms. It can be a primary delusional problem, or it can be secondary to a whole host of other illnesses, and I'll come to that in more detail later. Or it can be by proxy. And when it's by proxy, it usually means that the person who is ill feels that somebody else is actually infested. This is particularly problematic when parents think their children are infested, and we have had examples of parents putting their children into bleach baths to get rid of the alleged pest. We also have situations where people feel that their pets are infested, and I have seen one or two of them myself, and I believe that Nancy may be mentioning that later on. So we have a variety of different issues here, but it's important to make sure that we know what we're dealing with so that we can start the appropriate treatment. In the past, delusional infestation was known by other names. For example, delusional parasitosis, dermatozonenwahn, EKBOM syndrome, and a whole host of other names. I think if you go to our review in the 2009 review, you find that there were roughly 20 different names over the last 200 years. So we have a presentation normally to a family physician or a dermatologist. We very rarely get people to see a psychiatrist because they don't think that they are mentally ill. Obviously, they have a delusion, so they feel that the pest is really there. It's very difficult to persuade these patients to ever see a psychiatrist, which is why we feel that if you see them, you should try and get them to accept some help. But a psychiatric referral is usually the one thing that the patient will not accept. We often have a specimen sign, which means that the pests get collected, and I'll get back to that later. We often have signs of excessive cleaning, scratching, use of pesticides, and secondary itching and superinfections, because the skin lesions get very much infected. I talked about the reduction of social contact and reduced quality of life, and sometimes people use really dangerous attempts to get rid of the alleged pests, such as cutting them out of the skin or using toxic substances. We now call it delusional infestation rather than delusional parasitosis, primarily because the content of the delusions has changed over time. In the 19th century, people primarily believed that they were infested by scabies, typhus, or pest. In the 20th century, that moved first to insects, then later to parasites and viruses. And in the latter part of the 20th century, we started to see non-living pathogens being implicated. This century has seen the advent of fibers, threads, or unknown species to be implicated as the alleged pathogen, and this has become increasingly common. In English and German-speaking countries where the use of the web is widely done, we have the phenomenon of Morgellons disease, which is again another aspect of delusional infestation. It's another change of the content, so we have yet another pathogen that is implicated. In various studies that we've done, we found that even now most patients think that the pest is organic, and insects are most widely named. Parasites are only named in about 13%, which is why we don't think that parasitosis is still a correct label, but we think it's more accurate to call it infestation, because infestation emphasizes the nature and the constantly changing nature of the pathogens that are alleged to be the reason for the illness. We have about a quarter of people who now say that they are probably infested by non-organic or non-living pathogens like fibers, threads, or other things like that. We have no doubt that there will be changes again in the theme of the delusional infestation, because we have seen an ever-changing theme, and we're fairly sure that this is going to continue. It's a little bit like having people with paranoid delusions who say in the Cold War would be worried that the KGB is after them. Now they might be worried that terrorists are after them. So people change their delusional content with the times, and this is what happens in delusional infestation as well. Coming back to the etiology, when we have a primary delusional infestation, it means that people have this one delusion and are otherwise psychiatrically perfectly normal. So the only thing that isn't right with them is that particular delusion. In ICD-10, the International Classification of Diseases, that would be called a persistent monodelusional disorder. Mono because there is one theme, which is the infestation, and otherwise people are completely normal. Then we have the shared and special forms, and the shared delusion would be a folie à deux or trois, meaning that one or two other people also believe that they are infested. And there is usually one main inducer who originally developed the illness, but then persuaded his or her environment that actually they are infested as well. Normally the treatment is of the inducer, and if you get the others to live somewhere else, they will be all right without medication. So it's important to treat the inducer, you don't need to treat the others. In delusions by proxy, as I said, it may be children that are believed to be infested, or pets. When it is children, we often have to involve social services because there are often immediate child protection issues. When we look at secondary delusional infestation, we have a whole host of things that can cause delusional infestation as a secondary comorbid problem. Most common are actually not what I've mentioned in number 1, the psychiatric illnesses, but most common are 2 and 3. We have a number of medical illnesses, especially those that cause itching. And we have brain disorders, strokes in particular, or we have diabetes, uremia, jaundice, cancers, all of those illnesses that cause an underlying itching. Then we have substance misuse, particularly acute intoxication with cocaine or amphetamines. It used to be called the cocaine bug for that very reason, and these are then short-lived, so people would have the symptoms only for about a few hours. We have other medical medication, for example antibiotics, steroids, corticosteroids, or non-steroidal painkillers like ibuprofen or Voltarol or those kind of painkillers. They are known to trigger delusional infestation, which then goes away very quickly when you stop the agent that caused it. Particularly problematic are erythromycin. That is one that is commonly implicated. We have psychiatric illnesses, for example, major depression, schizophrenia, and most commonly dementia. So if we had to name 3 things that are most commonly implicated, I would name dementia, stroke, and cocaine and amphetamine intoxication. In terms of the age and sex distribution, you can see here the females are the dark blocks and the males are the light blocks, and you can see the ages, which makes it clear that it is primarily a disease of slightly older age, and females are more commonly affected than males. It is uncommon in adolescents and young adults, but not unheard of. So it's possible even in adolescence. Moving to the specimen sign, we had a recent study by Glyndwr in the United States, published in 2011, which had 108 patients. These were patients where they took skin biopsies of people who had presumed delusional infestation. What they found was that there was no evidence of any true infestation in any of the biopsies, and that the specimens that people brought with them were usually non-pathogenic insects. So that was the most common pathogen that was brought into clinic. 74% of people had a positive specimen sign. In other words, they brought something in saying, this is the pest. It used to be called the matchbox sign because in the early 20th century, people brought these alleged pests in in little matchboxes. Now the matchbox seemed to have gone out of favor, so we've called it the specimen sign instead, because we didn't find a single matchbox used as a container in the Hilver study. We did a study where only 4% used matchboxes and about half brought in the alleged pest. This was published last year with 148 patients. This was from our colleague Tony Bewley and his London clinic. I wanted to talk a little bit about delusions because I felt that when I talked to Alison about the web seminar, we felt it was important to maybe explain that a little bit from a psychiatric point of view. Karl Jaspers, the German psychiatrist, first talked about criteria for delusions in 1913, and he talked about an extraordinary conviction and a subjective certainty about something. In our example, this would be the subjective certainty that there is a true infestation. And this cannot be influenced by experience or logical conclusion. In other words, patients are absolutely convinced despite us not finding any evidence for any pest or infestation. And Jaspers talked about the content being impossible. And this is something that we look at more critically these days. He also talked about delusional elaboration, and this is when all other evidence is being used to prove the original hypothesis. In other words, anything that you will say, for example, I'm sorry, but we can't find any evidence for the pest, they will say, well, you probably didn't look properly, or the biopsy was taken from the wrong position, or the pest has probably hidden because they could hear you, or they might say that your equipment isn't appropriate or isn't good enough to identify the pest. So there will always be a reason why the pest wasn't identified. And the other thing that we find is that very often people actually have spend a lot of time to make sure that they can interpret all information within the context of their delusional system. So people, this can absorb all intellectual capacity, and we know of people who spend hours and hours every day trying to prove that their infestation is in fact real. Sometimes we have a real perception at the beginning, and coming back to my rat lady who believed her house was infested, it's quite possible that she might have seen a rat maybe in the garden, and that was the trigger for the belief that there were rats in the house. She, for example, then started to have auditory hallucinations where she could hear the rats when there were clearly no rats in the house. So this can have quite far-reaching consequences. But when we use Jaspers criteria today, in order to identify whether something is a delusion, we don't primarily look at the probability of the content. To give you an example, when we look at paranoid delusions and people tell you that the CIA is after them, we can't ring Langley and ask, are you after Joe Bloggs in Wrexham? So they would just laugh. So it's not always possible to prove or disprove a belief either way. So what we look at is primarily the way in which patients justify their belief. And that is what we need to primarily look at. So if someone says, I'm convinced the CIA are after me because I've seen 5 black cars today already, that is probably not sufficient evidence for the hypothesis that the CIA is after them. So that is the kind of thing that we look at. Another example I often give is that people with alcohol dependency often have delusions of jealousy, so they think that their partner is unfaithful. And if they come home and find their partner in bed with someone else, then it's probably not a delusion. But if they say, I think my partner is unfaithful because he or she was late from going shopping today, and she was 5 minutes late, that is probably not sufficient evidence to suggest that the partner is in fact unfaithful, never mind whether he or she is. So the fact that someone is or is not unfaithful is not the decisive problem here. And this is why sometimes with people with delusional infestation we may find something, but these are often things which are not actually responsible for the amount of symptoms the patients experience. For example, in the Glyndwr study, there were some non-pathogenic insects that were obviously objectively there, but these insects were not responsible for the symptoms that the patient described. So what we need to look at isn't primarily whether there is evidence for the pest, but it is the way in which the patient describes the alleged infestation. The more bizarre and absurd the description is, the more likely it is that it is actually a delusion. So we're looking at the explanation and the proof rather than the question whether there is or isn't something. When we then look at how these symptoms come about, we find that very often the starting point is the belief that someone is infested that arises quite unexpectedly. So all of a sudden, people either see something, or they have an experience of dirty circumstances, or just out of the blue, they feel that they are infested, and it's a belief that arises suddenly, unexpectedly, and it's falsely ascribed to the presence of an infestation. We all sometimes itch, but we don't think we're infested. We think, oh well, there's an itch, here we go, and that's that. But if you have the illness, then you will interpret that wrongly and think that there must be an underlying infestation causing you that itch. So we call that an error of probabilistic reasoning. In other words, the unlikely explanation is favored over the likely explanation. So the unlikely explanation of an infestation is favored over the likely explanation that there isn't actually anything wrong and it was just a random itch. So we have cognitive biases such as selective attention, because people then focus on their skin and they focus on their experiences. And if we spent all day trying to look for experiences, we would probably find some, because we would be oversensitized to looking for these things. Then the infestation gets blamed for the itch, and ultimately your belief evaluation system fails, and it doesn't reject the hypothesis of an infestation. So the unlikely then becomes your subjective truth, and then all alternative views are no longer allowed, and every further piece of evidence or any fact that then arises will be dealt with in that delusional system. So a negative biopsy will be dealt with by saying it was probably not the right part of the skin. Or very commonly people say, well, these pests, they're very clever and they only sometimes come out, and when they see a doctor they hide, or something like that. We have three big studies that are quite important, I think, to mention in the last 3 years. One is the Glyndwr study that I mentioned before. We find in that study that neither the skin biopsies nor the other very thorough investigation of the specimens and the patient found any objective evidence of skin infestation. in our London clinic, we looked at 148 patients, and we found that the specimen are normally skin particles, in contrast to the American sample where it was primarily non-pathogenic insects. So in London we found primarily skin particles, followed by hair and others. 35% of our patients in that sample thought they were infested by parasites, followed by mites, worms, insects and vermin, and 17% said they thought that there were some non-organic inanimate pathogens. We didn't find any infection in any of the patients. Then we have the American CFC, and we found that they had $3 million which was given to them because there was a lot of lobbying that went on. Hillary Clinton, when she was still a senator, was lobbying the CFC in order to get them to look into Morgellons. And for some time, they even took delusional parasitosis from their website under pressure from the Morgellons self-help groups. And basically, they investigated well over 100 people with self-declared Morgellons. They did a whole host of tests and found absolutely nothing. They did find a couple of random pathological results, but nothing that would in any way explain the symptoms or anything that was consistent. So they found the odd patient with the odd random result, but nothing that would explain the symptoms or that would be replicated. And this is typical that obviously if you take 100 people from the street and gave them such a high level of examinations, you would find the odd random result. But there was no evidence of any infection, infestation or other problem that could be identified. And these were people who diagnosed themselves with Morgellons. So you really can't say that they had that they had the wrong diagnosis. But still, the Morgellons lobby didn't consider that to be evidence that it is probably not an infestation. They carried on saying they probably didn't do the right investigations, as we would expect. So coming to treatment, the good news is that antipsychotics do work. And they work fantastically well if only we can get the patient to take them. And that is the big difficulty. We have an aggregate response rate of about 80%. So 80% of people who take the medication will get better. And better means that they are either completely cured or they are substantially better. But when you look at delusions, cure doesn't mean that people come to you and say, "Oh, doctor, yes, I realize I had a delusional infestation." Cure is that they would say something like, "The pests have disappeared. I just can't feel them anymore. They don't trouble me now. They must have gone." So that is probably what most people will say when they get better. Engaging the patient is absolutely essential, and for that we need to examine all specimens, because otherwise the patient won't believe us that we take them seriously, and we do take their symptoms seriously. We believe that they have the symptoms. We just have an alternative explanation why these symptoms occur, and that is the problematic aspect where the patients disagree with us, but we don't disagree that the patients have the symptoms. Dermatological complications are very common and usually need additional treatment. And we would always ask you to advise the patient to see a doctor. I don't think it's wise to advise anyone to see a psychiatrist, because they won't. But they need medication, and that medication can be started by a family physician or a dermatologist. So we advise dermatologists and family doctors to treat with antipsychotics. we are normally able to get away with doses that are far lower than that used in, say, for example, schizophrenia. So we would use doses that in schizophrenia treatment would be considered as starting doses. And that is usually enough, so we can normally minimize side effects. Specialist clinics may work, and with specialist clinics we mean, for example, dermatologists who have a psychiatrist sitting in with them. Or my specialist clinic is with the Institute of Tropical Medicine in Liverpool, where the tropical medicine consultant sits there and talks to the patient, and for the first at least half hour, all I do is sit there and look cute and cuddly, because otherwise people won't feel that they are taken seriously, because they haven't come to see a doctor to be told that their problem is psychiatric. So that usually comes as a shock to them. But if we, in the first instance, use phrases like unexplained dermopathy, then we often manage to postpone the discussion about delusional infestation. And I would not usually talk about delusions. I would talk about alternative explanations for their symptoms. Normally, when we get somewhere, we have patients who have tried a lot and nothing's worked. And what we often say is, look, you've tried all these things, nothing's worked. What have you got to lose by trying to look at an alternative explanation for these experiences? We also say that neuroleptics, which is the sort of less auspicious way of saying antipsychotics, help against distress, and that is true, so we can tell that to the patient without actually lying to them, because antipsychotics are being used for anxiety and for severe distress, and most of our patients are severely distressed, so we're not saying anything wrong by saying that they may just as well try them and it might help their distress, even if they don't believe our alternative explanation. We always need to look at dermatological complications, and many people need dermatological lotions and potions, sometimes even antibiotics, in order to treat the skin that has been cut, scratched, or infected. Very occasionally we use the Mental Health Act, and that is normally when there is enormous risk or when children are involved. So that is something that occasionally has to be considered. So to summarize, I think that the main aspect of delusional infestation is that we often have people, in about 50%, we have people who don't have anything else wrong with them other than the delusional belief that they're infested. The infestation is commonly about organic pathogens, but in about a quarter we have non-organic pathogens. I think the cases where people feel that the whole house is infested by vermin are a minority, but they're a sizable minority. Most people feel they're infested by much smaller pathogens. The illness is extremely absorbing. It produces enormous difficulties with social contacts, with relationships, and people have a high level of objective and subjective suffering. Unfortunately, because it's a delusion, the last thing they want is to see a psychiatrist, which means that we usually have to get the family doctors or the dermatologist to work with a psychiatrist and prescribe the medication. So if you have a high level of suspicion and you advise someone to go to see a doctor, it might be worth actually asking who their family doctor is and talking to that family doctor. I have one patient myself who is a retired professor of education who had this problem, and she had a pest controller in her house twice, and the pest controller kindly said to her that he felt that there wasn't a real infestation and that he would recommend that she sees her family physician. She did that and actually then eventually came to see me because she was willing to accept that there may be an alternative explanation. She's now on medication and all the pests have completely disappeared. So it was the pest control officer who said that to her and really started her on a path to cure, really, and to a much better quality of life. So we can see that we can make a difference, but we shouldn't be disappointed if we don't succeed with everybody, because this is a delusional belief and people are very reluctant to look at alternative views. So we can probably help maybe 50% if we do it very well. And doing it very well means that we are very sensitive when we speak to people. We try to plant the seed of them looking at alternative views and seek medical help. So that is probably the best that you can achieve when you're in the house and you're with that person and you have a high suspicion that they actually have a delusion. Right, that's it from me, and I think Nancy is the next speaker. Thank you very much.
I'm going to have one question before we switch the slides over to Nancy. So I have been recording questions that folks have been sending to me, and I'm going to ask them in order. Ones that we don't get to, I will email to our speakers, and we will post the answers to them with the recording after today. So the first question that came in, if you could answer it quickly, Peter, was how can an individual with delusory infestation convince their family that they have the same infestation? How does that usually work?
We don't know, because the interesting thing is that when we scan the brains of people with delusional infestation, we find that they actually have problems with very specific dopaminergic pathways that are responsible for the way in which we interpret sensory input. We haven't ever scanned the relatives who also believed that they were infested. So we don't know whether they develop a brain lesion. Personally, I doubt it. Personally, I think that the intensity of the belief is such that they eventually manage to persuade sort of not quite so strongly minded family members. And I think it's a strong persuasion rather than a sort of chemical change in the brains of those people. I forgot to say as well that in terms of what medications are most useful, we use very dopaminergic antipsychotics. So we use amisulpride, risperidone, olanzapine, or very successful are also the older antipsychotics such as sulpiride or haloperidol. We don't use pimozide, which has in the past been propagated because of its side effect profile. So that's something we wouldn't use anymore, even though it's in most of the old textbooks, because we have now medications which do the same with far fewer side effects.
Wonderful. Thank you. And for those of you who have asked questions, I appreciate those, and we'll hopefully have time at the end. But to keep us on time, ending at noon, I'm going to switch the presenter privileges over to Dr. Hinkle. Dr. Lepping, please put your line on mute. And Dr. Hinkle, you should be about good to go.
Thank you, Allison. Well, after Dr. Lepping's very excellent overview of the medical aspects of this condition, it's now my task to discuss why the claims made by these individuals suffering from this delusion do not comport with biology. We'll also talk about how we can differentiate an actual arthropod infestation from a delusional one. As Allison mentioned in the introduction, I'm a veterinary entomologist, and my research focuses on fleas, ticks, lice, mites, and other creatures that infest animals. So many of our callers are convinced that they acquired their infestations from animals and assume that a veterinary entomologist is the most likely person to know how to diagnose and treat their condition. Let me clarify now a term that I'll be using repeatedly. In biology, the term infection is used to indicate the presence in a living host of a microbial pathogen, such as a bacterial, viral, or fungal infection. By comparison, presence in the host of a creature visible to the naked eye is an infestation. So we speak of a bacterial infection, but a lice infestation. Now this picture shows one of our callers with lesions covering his body where he had used his knife to attempt to extract the mites that he just knew were burrowing into his skin. Although we entomologists have historically called this condition Delusory parasitosis, as Dr. Lepping mentioned, my psychology colleagues have pointed out that the term delusory or delusional is stigmatizing and alienating. So we have switched to using the clinical term EKBOM syndrome, which is what I'll probably use mostly today. In the 20 years that I've been keeping records on this condition, the primary complaint of the majority of sufferers is they feel something crawling on them, a symptom known as formication, and notice that's F-O-R-M-I-C-A-T-I-O-N. Formication is the term for the sensation as of an insect crawling on the skin, from the Latin word for ant, formica. It's a tactile hallucination involving the belief that something is crawling on the body or under the skin. Now, typically, this tactile hallucination is accompanied by a visual hallucination in which the sufferer observes material on the skin, such as lint or scabs, but he perceives this material as insects. Now, they are exasperated that no one else can see the insects that they're finding all around them. Knowledge about insects among the general populace, as you know, is quite low, so descriptions of putative insect infestations are rarely coherent with known biology. So let's run through a few of the arthropods that get blamed for infesting humans. Spiders do not bite humans. Spiders do not suck blood. They feed on insects and bite humans only when they feel threatened, like when I grab one and try to hold on to it long enough to get it into a cage. Despite the lore of urban myths, spiders do not climb into our beds at night and bite us. If someone wakes up in the morning with itchy welts all over their body, then our first thought is going to be bed bugs. But there are no burrowing bed bugs that infest human skin. Bed bugs do not crawl on people while they're awake. Bed bugs, as you can see, are not invisible. Bed bugs cannot fly. In fact, they're wingless. And bed bugs, therefore, do not fit the descriptions of invisible bugs at all. Scabies is a condition that's caused by the mite Sarcoptes scabii. This mite does truly infest human bodies, and it is the only mite that does. Scabies mites burrow into the top layer of the skin, creating tunnels just under the surface, and within these burrows they feed, defecate, and lay their eggs. Scabies mites cause itching due to the body's immunologic reaction to mite feces, eggs, and shed skins that are left behind by the mites. And scabies mites do not infest the entire body, but are found in specific predilection sites, particularly the webbing between the fingers and the dry skin on the elbow. Scabies is virtually never found on the head or scalp. The mites are too small to be felt crawling on the skin, so they do not explain the sensations that EKBOM sufferers describe. Chiggers are another type of mite, but this mite is not adapted to living on humans. In nature, chiggers feed on lizards and snakes. When they do accidentally end up on humans, they will attempt to feed, but they cannot survive on humans. Chiggers are, of course, seasonal, so you won't get a case of chiggers in the winter. And they produce only itching. They're too small to be felt crawling on you. They do not infest homes, but are exclusively outdoor mites. Because sufferers are unable to see what's crawling on them, they immediately latch onto the name no-see-um. These are biting midges that will leave you itching just like a mosquito bite. Because they're so small, they can often bite and depart without ever being seen, leading to their common name, no-see-um. So people who claim they are suffering constant biting sensations attribute their suffering to no-see-ums. However, as you can see, they are not invisible. They are seasonal, so you're not going to encounter them in the dead of winter. And they are strictly outdoor pests, never entering homes. They cannot bite through clothing, so biting sensation under clothes can't be produced by no-see-ums. And again, you cannot feel them crawling on you, so they do not account for the formication sensation. Springtails feed on fungi, so they may be found in damp bathrooms feeding on mildew. They hop like fleas, so they're often mistaken for fleas. And when they end up in the bathtub, they show up very well against the white porcelain background. Springtails cannot bite or sting, and they cannot infest human bodies, so they're completely harmless. Now, one website that I would like to eliminate from the net is birdmites.org. I don't doubt that those people responsible for this site have good intentions, but they promulgate errors and misinformation that have added to the suffering of innumerable people. Bird mites are strictly adapted for feeding on birds, and they cannot survive on mammals. When deprived of an avian host, they may, in desperation, attempt to feed on a human or other mammal, but they cannot survive on our blood and will starve to death within a few days. So they are totally incapable of infesting humans. They can be felt crawling on our skin, and they produce itching when they bite, but they cannot survive on us, and they are readily visible without magnification. As Allison mentioned, I have studied avian mites for over 2 decades. I've been covered in bird mites while working out at the poultry farm, and neither I nor any of my coworkers or students has ever become infested with bird mites. EKBOM syndrome sufferers typically submit materials such as shown here, believing that they are providing bugs. However, it is apparent that they are scraping off bits of skin, scabs, and dried blood, after experiencing the visual hallucination that these are bugs. Remember, these people are not making it up. They are absolutely, totally convinced that it is real, that bugs are infesting their skin. For instance, this lady, a nurse, spent hours with tweezers every night pulling the lids, as she called the scabs, off her sores, quote, to let the bugs out. As a nurse, she knew intellectually that there was no insect or mite that burrowed into human flesh, and yet the delusion consumed her. As Dr. Lepping mentioned, the delusion of being infested with bugs is well known in law enforcement circles, where meth mites and cocaine bugs are frequently described by individuals using methamphetamines and cocaine. In this case, the drugs are producing the delusion, and as he said, we don't know what produces the delusion in other EKBOM sufferers. Also, as Allison pointed out in her introduction, we caution pest management professionals to always identify the pest before making recommendations for its remediation. If pest control companies start treating for invisible bugs, they risk committing themselves to a never-ending cycle of customer complaints and retreatments because they cannot hope to eliminate non-existent bugs. We request that sufferers provide samples on clear adhesive tape. I'm interested in what's on the skin at the instant they feel the sensation. If they immediately place the sticky side of the tape against the skin, whatever is on the skin and producing the sensation should logically become trapped in the adhesive. And using clear tape then allows me to examine the specimen microscopically from both sides. We have never found insects or mites in the samples provided. Typically, we find skin debris as shown here, scabs, hairs, sloughed skin, and such. Again, lint and fabric pilling are the 2 most commonly submitted items, usually helpfully circled by the submitter. So in summary, there are only 2 groups of arthropods that infest human bodies, scabies mites and human lice, and the human lice include head and body lice as well as pubic lice. Because these live exclusively on human bodies and are acquired only from other infested humans, there's no role for pest control in their treatment. They are strictly medical conditions. So what can we conclude entomologically? Well, there's no insect or mite that can live in the environment and then switch to infesting the human body. There is no insect or mite that can feed on inorganic material like nylon or rubber, so they cannot feed on furniture or clothing. Frequently, we have callers claiming that something is chewing holes through their clothing and then burrowing into their skin, but there is no mite or insect capable of that. There are no winged insects that infest human bodies. Lots of people claim to see something flying out of their skin, but no insect can do that. There are no invisible mites or insects that infest human bodies. In fact, there are no invisible mites or insects. Microscopic, yes, but not invisible. There are no external animal parasites that can infest humans, so you don't have to worry about picking up an ectoparasite from a dog or a cat or any other animal. Bird mites cannot infest humans, nor can rodent mites or any other animal's mites. Human body infestation is a medical condition and must be treated by a physician. While we're always polite and respectful to our callers, we are careful not to feed into their delusions. We are cautious to call the wounds either sores or lesions, but never bites. We always remember that if we, the authority figure, confirm what they suspect, it validates the patient's conviction of infestation. And also remember that you're only hearing how the sufferer perceives and interprets, as Dr. Lepping mentioned, the experience, which may not reflect reality. Pest control companies should monitor and evaluate the situation, but treat only when a target pest has been identified. Treatment obligates the company to continue treating until the situation is resolved, and with EKBOM sufferers, the situation will never be resolved. Now, admittedly, this can be very challenging when dealing with a long-term customer, especially when it's a sweet elderly lady who can't understand why you refuse to help her with her problem. In conclusion, EKBOM syndrome is a medical condition and requires medical treatment. There's no role for pest control or entomologist in dealing with this condition. If you run into situations where what's being described doesn't square with what's biologically feasible, you may want to consult with an entomologist to find out if insects or mites are even capable of what's being described. As physicians become more aware of this condition, the ideal situation will be, as Dr. Lepping described, that we entomologists and pest control operators identify people suffering from EKBOM syndrome and refer them to their personal physician, and then the physician will recognize the condition and ensure that the sufferer receives the medical treatment that he or she deserves. These people are suffering. We want to help them. Thank you.
So we are closing out the hour here, and I'm going to ask one question. We've received a number of wonderful questions. There are some themes to the questions, so I am going to order those and get them answered by our speakers, and we'll make sure to post the answers to the questions with the recording and the PowerPoint on StopPests.org. So please continue to send your messages or your questions through the chat box. I will make sure that those all get answered. I'm going to ask this one question, and then I have a few closing remarks. So the one question for both Dr. Hinkle and Dr. Lepping, so you can take both of yourselves off of mute. When a person with DI only wants to talk about the infestation and gets angry when people don't believe them, how can or should a family member respond or talk about it? So I'll leave one of you to answer that question.
I'll leave that to Dr. Lepping. That's a psychology question.
Well, to be perfectly honest, it's going to be very difficult for that family member. And what we would advise is that the family member does exactly what we would do as clinicians, which is to agree to disagree. Because there's no point having an argument about it, because you're not going to change their mind. Equally, you're not going to help by confirming the delusional belief. So the best thing to do is to say, well, I don't think that this is the case, but I don't think there's any point arguing about it, and maybe we just have to agree to disagree on this. So it's important to try not to get into protracted arguments, because that will only escalate the situation, but equally by confirming the delusion, nothing is gained, and it'll only make the situation worse in the long run. If possible, if they trust you enough to say, well, maybe we should look at alternative explanations, and why don't we go to a doctor, and why don't you look at possibly trying something else, and we see whether that might be more successful than what you've tried so far, then a family member might be in a good position to persuade the patient to seek help.
Wonderful. Thank you for your answer. So as a follow-up to this webinar, please feel free to email me any questions that occur to you after we end the meeting. My email address is stoppests@cornell.edu. Those who registered will receive an email when the recording is posted. Included in that email will be an evaluation form and an opportunity for you to suggest future webinar topics. Our goal is to improve pest control and affordable housing by teaching everyone who works, lives, and plays in housing how to use integrated pest management, so we really welcome your feedback. If you are from an affordable housing agency and would like to work directly with a StopPest consultant to implement IPM at your property, please fill out the request form at the top of stoppest.org. I'm extremely grateful to Dr. Lepping and Dr. Hinkle for sharing their knowledge, and of course none of this would be possible without our funders, HUD's Office of Healthy Homes and Lead Hazard Control and USDA's NIFA.
Thanks for organizing this, Allison. We really appreciate it.
Thank you.
Thank you.
Thank
Take
you.
care. Bye-bye.
Bye.
Thank you very much. Bye-bye.
Thank you all for attending this webinar and for doing your part to stop pests in housing. Have a wonderful day.